Both options were supported by the Northern England Maternity Clinical Network, but it was recognised that option 1 offered a greater choice of birth options to expectant mothers. There's a high level of confidence that safety and quality will be improved with an increase of consultant cover on obstetric-led units to 84 hours a week. And the strategic alignment with the Better Births policy is much greater with option 1 in terms of the choices that expectant mothers would have with the introduction of that freestanding midwife-led unit, and that's very much in line with NICE guidelines. I think option 1 presents a great opportunity to develop a freestanding midwife-led unit that could become a holistic, community-facing birthing centre for both the population of South Tyneside and Sunderland, and has the potential to be right at the heart of the local community. Whilst the IIA gives positive scores for both options, the scoring is somewhat higher for option 1. And the IIA determines that both options will give children a better start in life and could therefore deliver enduring and significant benefits to child health, population health, and improve inequalities across both populations. The positive impact is judged to be across both populations equally. The IIA does, however, note a number of considerations for us in implementation, not least around information for patients and the public, establishing a cross-area women's services user group, and specifically thinking about plans for breastfeeding initiation, which is a key issue for both populations. In terms of the public engagement and consultation, notwithstanding the previous points that David's made about the views on the status quo, we noted that option 1 broadly had greater support than option 2, but particular consideration we've given to the feedback about consultant presence and clinical safety. And we recognise childbirth is not a simple process. However, the evidence is categorically clear that FMLUs, freestanding midwife-led units, are at least as effective and safe as obstetric-led units. And we heard that throughout the process from the clinical experts who came to present to the governing bodies. A key, though, is that we start with really rigorous risk assessment for expectant mothers. And also we noted that the availability of senior doctors is a key driver behind the need for change. We noted concerns from the public about the need for transfer, what happens when a low-risk birth becomes a high-risk birth, and the ability of NIAS to respond in those circumstances. We recognise that as a key concern. Again, I think it's important to note the clinical evidence is clear that freestanding midwife-led units are at least as safe as obstetric units and may well be associated with better outcomes. We have now had clear assurance about the stratified risk transfer of patients from NIAS and the local clinical teams. NIAS have confirmed that the freestanding midwife-led unit would not be considered as a place of safety, and hence it will be prioritised accordingly. And that was a key concern for the clinical teams.
So I had some safety concerns. I could hear the views of the patients. As many of you know, I was born in South Tyneside and lived there as well for a long period of time, so it was close to my heart. And I did have concerns about the safety in particular of midwifery-led units. I think for me, what I reflect back was the presentation in particular that we got from Professor Sturgis, which was really quite evidence-based and really robust. And what that presented to me was I could feel the feedback from the communities and the patients that was important to them. Yet I had the clinical doubt about, I had sustainability, and I think we've still got that concern, we've had that aid, but I had clinical concerns as well. I think what he brought was an absolute clarity that elsewhere in the country this could be done. And I think if the governing bodies go with the recommendations as presented, it is absolutely essential that as a partnership between commissioners, providers and patients, we do commit to making this a centre of excellence, looking at best practice around the country and put 100% of our efforts into making this unit the best success it can be. And for me, as a convert to it, that's taken me on quite a journey. So I just wanted to hear the concerns. I've been there myself. I think as we go towards the recommendations, if we do that, I think we should realise it's in partnership to get such a unit to work at its best capacity. The impression I was clearly left under was it required a strong partnership between commissioners, providers and patients. So I just wanted to feed that back to both boards. Thanks.
Yeah. And I think it's important to note that the option was also reviewed by the Northern England Clinical Senate specifically, which supported this pre-consultation decision not to take that option forward. It's also important to note that during the consultation period, a further transitional care SCABU model was proposed by staff and supported by the programme team as much as possible to be worked up for full consideration. That option is outlined on pages 46 to 48, but it did not pass the hurdle criteria, particularly given the feedback we've had from the Neonatal Network, NHS England Specialised Commissioners and the National Quality Surveillance Programme. External partners have been clear that they wouldn't expect this model of service to be considered as an alternative to superior level care. So the recommendation we're making is on the basis of all the evidence we considered throughout the process, but not least, that there are conflicting views about the preferred options across local clinical teams and external clinical partners, including the Northern Child Health Network and the Northern England Clinical Senate. The Northern Child Health Network noted that both options are credible attempts to address the significant workforce challenges, but that option 2 is most likely to support medical staff retention and deliver long-term workforce sustainability due to the concentration of paediatric acute emergency services. They identified no issues to question the safety and clinical efficacy of the proposals, and the view was that both options are in line with the available clinical evidence base and informed appropriately by clinical standards. The Northern England Clinical Senate noted that option 1 was the closest to being a workable solution and could potentially be implemented incrementally to build confidence in it. It noted that option 2 had unquantified risks that needed to be addressed. However, it's felt that these risks can be properly mitigated through taking a long-term approach to implementation, with option 1 as a transitionary model, as we set out. I think we should really note the Northern England Clinical Senate noted the passion of local medical and nursing teams for their populations and the care they deliver to their populations. And critically, the Northern England Clinical Senate noted the urgency of the decision we're making today, given the fragility of the service. While option 1 is more deliverable in the short term, it does not address the underlying issues relating to medical staffing that are the fundamental driver for change. And therefore, although option 2 will take longer to become deliverable, it's felt to be more sustainable in the long term, not least because it does address those medical staffing issues. Clearly, medical staffing concerns will mean paediatric services remain vulnerable throughout implementation. We've had suitable assurance from NIAS around patient transfers in the letter we've had back from Matthew Beattie on behalf of the board, and this guarantees the unit would not be regarded as a place of safety, much as Ian indicated earlier.